On to our last speaker, who is by no means the least, Dr. Kian McDermott. And Kian and I have, worked on a lot of ultrasound courses in Ireland. He was doing ultrasound well before I did ultrasound. I need to give him a proper introduction. So Kian, your intro here, as you had suggested, was that of the sumo wrestler. And I hope you like some drums, Japanese drums. So Kian McDermott is, he's an emergency medicine consultant in the Mater in Dublin. He's the director of emergency ultrasound education in the Mater. And you may well know him from, if you attended any of the ultrasound workshops at the SMAC conferences. He is a co-director for the ultrasound workshops for SMAC, and now known as CODA. So I'm going to leave you with Kian.
Hi, Nick. How are you? Thanks for the opportunity to talk to everybody today. Can you hear me okay? And can you see what I have on my screen?
Indeed. Yeah,
great. So yeah, you texted me and said, what's your intro music? And I texted the first thing back that came into my head. I have no idea why I asked you for some Eastern sumo wrestler music. So I'll just get that off the table. And also, this is the first time I've started a talk with a hashtag, and I'm doing that for you because this hashtag is really, really useful. It's Echo First. It's a treasure trove of kind of echo FOMED out there. So to get onto the case itself, things I hope to answer over the next 10 minutes, how useful is echo in PE and how to identify that right ventricle at risk. We see lots of PE in ED and obviously in ICU as well, and I think that's the incidence going to go up and up in the kind of post-COVID environment. So I'm trying to tease out that group of people that might need higher level intervention. They've already been confirmed as having a PE or you're suspecting a PE. And I'm going to pick through a few images from a case that I had recently about 2 months ago. And like Peter, I was not sure exactly how to pitch this, but I think I might have got it right. And that's the advantage of being at the end, because I've stuck with mostly 2D images, which should lead you towards the right diagnosis, and I've thrown in a little bit of color Doppler and my new friend spectral Doppler as well. So let's see how this goes. Cool. I think I based some of the talk off this paper. It's a recent paper that was published, and I like when a talk presents a paper because I can take a picture of that paper and go and read it afterwards. So I'd suggest you to do that as well. So it's a paper that describes kind of the echographic or sonographic signs that will show you, they will describe how that right ventricle is strained and how it's under pressure, and that those signs might suggest a pulmonary embolism. So just note that wording as well. So echo signs that suggest RV strain, and one of those reasons for an RV strain might be a PE. So I don't think echo is the best modality to diagnose PE, but we can use it to help us to risk stratify that right ventricle at risk and maybe intervene basically on the basis of that. Just a little bit of background in terms of that right ventricle. It's totally different to the left ventricle. You start to appreciate that when you start to image it, and I suppose you guys that work with ventilators will see that a lot as well in the intensive care unit. So that right ventricle is thin-walled. It's a low-pressure system. It doesn't need to have high pressures. That pulmonary circulation is low, and basically the right ventricle keeps that open and keeps blood flowing into the lung bed. So because of that, it's really sensitive to preload and afterload changes, and the right ventricle is very much influenced by what happens at the level of the lungs. And this is very much different to what happens on the left side of the heart, but they both share a similar house. So they have to get along with each other. So an acute rise in the pulmonary vascular resistance then can cause right-sided failure. And in PE, and I think we should really call it pulmonary artery embolism. We leave out that artery a little bit. It's a bit of a misnomer. A thrombus is lodged in that pulmonary artery. It causes an obstruction to flow, right ventricular afterload, or the pulmonary vascular resistance goes up. And then that right ventricle, because it's so sensitive to pressure changes and volume changes, it starts to blow out and dilate. And what I want to show you is a case of where that has happened acutely. And notice also that that right ventricle will recover pretty quickly afterwards once the pressure is either been removed or the condition has been resolved. So the first case, or the only case we're going to talk about, is a 50-year-old lady with a previous DVT, had not been taking her medications, lost to follow-up to our thromboembolic service. Risk factors unclear apart from that, and she had a short history of pleuritic chest pain and dyspnea. Normal tensive, which is good. Mild dyspnea on ambulation in the ED. So when she walked down to my little echo room, she was moderately short of breath, and then she had a troponin of 700 and a BNP of 2,300. So we're in kind of tricky territory at this stage. So what you see here is bilateral PE and a reasonably high clot burden. And the question, we know she has that diagnosed on PE and on CT, and we need to figure out what do we do next. And I think I needed to have a look at this right ventricle and left ventricle to see what that right ventricle is doing. Was it stable? Was it failing? And what the strain pattern was, because we had a definitive diagnosis already made on CT. And I think that's probably the way we should go. So let's see what we saw. So this is a parasternal lung axis view, and on the top of the picture you have your right ventricular outflow tract. And what I'm trying to do here with these series of images is build up the picture that evolved in front of me. Like Peter, you know, you're scanning away and you see a picture that develops in front of you, and gradually the whole clinical picture dawns on you, realize that a patient is quite sick in front of you. So this is a parasternal lung axis view. First thing that stands out for me is that right ventricular outflow tract, and I think we should start to use that terminology instead of kind of just saying it's the right ventricle. We need to understand how it's the right ventricular outflow tract that you can see close to the top of the screen. And either way, whatever you call it, it's larger than you would expect. So in terms of relative proportions, what you want is your right ventricular outflow tract, your left ventricular or outflow tract, and your aortic root and annulus, and your left atrium. They all should be a similar size, and they take up a third and a third and a third, roughly speaking. But this RVOT is bigger than I would expect, and that catches my eye. And that kind of artifact that's coming across the screen, that's her being tachypnic. And she is tachycardic as well. She's just not 198 beats per minute. I'm not sure what was wrong with my ECG trace, but all of a sudden you're suspicious of a right ventricular problem on this from this echo loop. So again, this is a parasternal short axis view, and it is at the level of the mitral valve apparatus. And I do have other images, but I think this one just kind of showed what was happening with her relative pressure changes. So there's abnormal septal motion here. If you have septal systolic flattening, then that indicates pressure overload, and then diastolic septal flattening indicates volume overload. And in actual practice, what happened here when I slow down the loop, she has a bit of both. But I think the predominant feature, when you build up the case, it's a pressure overload phenomenon for her. And this is the whole concept of ventricular interdependence. So the right ventricle and the left ventricle, they live beside each other and they share a wall in the same house. They share that interventricular septum. And what happens in this case with the pressure overload on the right side, the septum bows over and pushes into the left side, which has knock-on effects for that side. So the pressure rise occurs in systole and a volume rise occurs in diastole, and it's useful, well, I always do it now, to have your ECG loop. So that's the first controversial thing I'll say is, should we be considering an ECG loop? In most of the cases, I think it's something that I do all the time now. So have a look at that loop and see what you think. So it's that abnormal septal motion. So I've gone ahead and got an apical 4-chamber, and I've zoomed into the right ventricle for a couple of different reasons. I've looked, once I started to figure, I'm looking for this thrombus in transit. Again, I won't see it often. I'll probably pick it up once or twice in a career. And that's, if I hadn't had a CTPA, that would probably be the only thing that would convince me that a PE is present. Either that or somebody that had a big clot in their femoral vein. But I'm looking for that thrombus in transit because I know our IR guys can do something about that in the short term. So we've a few signs of a high pressure system on this loop. So if you start at the annulus, the tricuspid valve annulus, and move a little bit beyond it, you can measure the basal diameter. And that basal diameter, it's allowed to be 41, 42 millimeters. in diastole, and when I measured that out, it was closer to 50 millimeters, and that's the first sign that that RV is dilated. So you can do that, and you can slow down the loop, or you can measure the relative proportions when you look at right side and left side. But if you're actually going to measure it out, that's what it was. So that RV is dilated. Another little thing, you can't see it so well, but you'll see it nicely in the next clip, is that moderator band. So that's a piece of tissue just about here, 2/3 of the way up along the right ventricular cavity, and that's flattened out, and it usually occupies a kind of a 45-degree angle like that in a normal right ventricle, and it's flattened out because the right ventricle is dilated. So it's another sign of right ventricular dilation, really. So you'll see that a little bit neater in the next piece. Now, have a look at the the RV apex, and that's the thing that caught my eye the most on this piece. So that RV apex is hyperkinetic, so moves faster. It's more mobile when you compare that to the motion of the right ventricular free wall, which is on the left-hand side of the picture as you see it. And that shouldn't be the case. They should move roughly in conjunction with each other. You shouldn't really have one area moving slower or faster than the other. So that's McConnell's sign. And it's specific for PE, but it can also be a sign of right ventricular strain. And what happens is your right ventricular free wall myocardial fibers, they become stretched, they're ischemic, they become sluggish. But the RV apex is now behaving like it's part of the left ventricle, and it's been pulled along and dragged along by that left ventricle. So there's a relative mismatch in the way that they move. And again, that sign is reasonably specific for PE in a group that you have a high suspicion for PE. So just notice that. It's a nice one to pick up. And again, have a look. You've seen already abnormal septal motion in one view, and we've said it over and over again. Look at it in multiple different views. So if you slow that loop down, again, you can see the right ventricular, interventricular septum is pushing over into the left-hand side, and that's a reversal of the normal pressure relationship that exists between the left and the right. So this is an RV focused view, and you get that by sliding out laterally. And you explained it very well in one of your recent tutorials, Peter, from your Twitter account for one of the live broadcasts. And you slide this out, the probe out laterally, and you have the RV free wall is now vertical, and you're allowed to have the interventricular septum. You're allowed to have that at an angle, and it just helps you to appreciate the size on the movement of that right ventricle. So again, I think you can see it more clearly here as the loop develops. You can see that moderator band, and it's flat, so that RV is stretched and strained. And that right atrium does not look like it's the correct size or proportion to me either. And I'm slipping in and out of an apical 4 and an apical 5 view, which is easy to do, but you have to watch out for it. That right atrium looks enlarged, and you'll see why that happens in a moment. And have a look right down here at the level of the intraatrial septum. This right atrium is enlarged, and it's bowing and pushing out into the left atrium as well. So another sign that the whole right side, the right ventricle inflow tract and the outflow tract, is now under pressure, or more so than you would expect. So in this view, mislabeled, I know that, it's the M-mode cursor is along the line of that right ventricular free wall, and that's probably why it's nice to line up that to get a RV focus view and line up the cursor nicely with the M-mode, so you can actually take a nice M-mode picture. And I'm measuring here TAPSE, which is tricuspid annular plane systolic excursion, and that's the way or the amount of vertical displacement of the tricuspid annulus up towards the apex. And it's probably a reasonable measure of the RV function, since there's quite a high proportion of the RV fibers actually move in that longitudinal fashion. So when you look at it, the magic number in our head should be 16 millimeters or more, and in this case it's 21 millimeters, so it's exceeding that. So the RV is actually functioning quite well, even though it's dilated and it has a high pressure on that right-hand side. Okay, so we'll build up the picture a little bit more. And here's where things turn out to be a lot of fun. When you start to put color through valves, and I think if we can get high quality B-mode images, the next step, if you're on your Fusic journey, is to start to put color through valves. And it really opens up the whole world of echo. And that's what I've done here. So I'm putting on color flow Dopplers to see what that blood pool is actually doing. And my images are similar to Peter's, except his was on the left-hand side and mine is not just as wide open or torrential. But remember that blue is away from the transducer and blue is the transducer is at the top of the screen. So blue means that there's a blood pool, bleeding back into that right atrium. And that's probably the reason that the right atrium is now enlarged as well as the right ventricle. And so that tricuspid valve, we think in this case, it's probably secondary to the right ventricular dilation. So it's a functional tricuspid regurg. And so the valve itself might be working well, but it's stretched apart by that dilated right ventricle. And that jet kind of extends a long way back into that back wall of the right atrium. So it's significant. And again, you can see that intra-atrial septum bowing out to one side. So you start to build up the picture of a right ventricle and a right atrium that's under pressure and stretched and strained. So again, if you're doing some advanced echo, you really will need to get on top of Doppler, and we see here a nice Doppler envelope it's a continuous wave Doppler envelope right through that TR jet. And it basically measures the velocity of the blood pool as it moves backward through the valves. And then the machine converts it into a pressure gradient that exists between the right ventricle and the right atrium. And then you add on the right atrial pressure to that pressure gradient that you get. And that's the magic number for the right ventricular systolic pressure. And you'll hear that figure quoted a reasonable amount. So your right ventricular systolic pressure shouldn't really exceed 25 millimeters of mercury, and we need to go and have a look and correlate that with a right heart cath as well if you're measuring pulmonary hypertension. But in this case, you've kind of used an echo non-invasively to go and say that your RVSP is well elevated. So it's at 51, and I still haven't added on my right atrial pressure yet at that stage. So we know that your RVSP is elevated. And Doppler is definitely on the more advanced side of echo, but it's very useful to give you more information about what's going on at the level of the right ventricle in terms of pressures. So like Peter, I'm a fan of that subcostal view, and I think all the presenters today have shown at some stage a subcostal view, whether it's for a tamponade or whether it's for this sort of case. It just gives you a big, broad picture of what's going on, and you can see, in this case, you can see a large right atrium, and it's probably more for a qualitative rather than a quantitative view. You see this, but again, I'm looking at different views to confirm what I've seen. And again, I see my intra-atrial septum bowing over into the left atrium. So I know this right ventricle and right atrium is now dilated. It's under pressure, it's under tension, and I've made a measurement of my RVSP. So at this stage, let's kind of stop and put all of this together. I have a CT confirmed PE with a high clot burden. I have multiple views and standard and some non-standard views that show a dilated right ventricle. That tricuspid valve is stretched and there's tricuspid flow regurgitating back through the valve. And there's high pressures on the right side. And we've tried to quantify those. But the left ventricle function, and you can see it on this view here, looks preserved. And that's probably a good thing in the context of this case. So this patient is normotensive, and that being the case, you're dealing with a submassive PE or an intermediate risk PE, depending on which society guidelines you're working off. But I think this is definitely a case of an at-risk right ventricle. And it's a right ventricle that's kind of on the higher side of the risk spectrum. And all the clinical pictures or all the clinical pieces of information and echo features, they're congruent. And that's really important, especially when you're starting out in echo. You can let your echo findings get the better of you and kind of run away with nice pressures and pictures, but it has to tally with the clinical findings as well. So I suppose why I'm describing this to you is just to convince you to use echo, whether it's B mode or whether you're moving on to level 1 or level 2, use it to assess a right ventricle that's under strain, and it shapes your thinking at an early stage. And it might move you towards more aggressive treatment. So maybe something like clot retrieval or lysis if the patient becomes unstable. So you're not going to be surprised when you see a right ventricle like that if a patient does eventually go on to become unstable. It just gives you a heads up of what you're dealing with. So what happened with this case, our hospital PERT team was activated, a pulmonary embolism response team. And I know that sounds fancy, but it's literally no more than a group of kind of interested physicians on a silo group that kind of text each other for advice and say, what do you think of this? What should we do? So our IR person came down to ED, consented this lady for intervention if it worsened, and she spent an overnight stay in HDU on a heparin infusion, and her clot dissolved, or certainly her hemodynamics restored themselves. So this is a repeat echo a couple of days later, and I've committed a cardinal sin. I've taken a video of this on my phone. Unfortunately, I couldn't get it off our EchoPack system, and our images are flipped. So what you're seeing here on this side is now our left-hand side. It's our left ventricle, and that's the way it's done in our hospital sometimes. And this is our right ventricle. So you can see that the normal relationship is re-established between left and right side. So her hemodynamics and her pressure volume relationship has kind of been restored after heparin and after treatment for this. And you saw the original images that I saw, or that I took in ED, that kind of landed her up in HDU. So that paper that I just showed you at the start, this is a really nice summary on the echo findings. Some of the authors produced this, not me. And I think it kind of shows three stratifications of how you might use echo to identify that at-risk right ventricle. So along the top, you have your sizes and your abnormal septal motion, a McConnell sign, and a bit of tricuspid regurg. And you can find most of these signs with B-mode 2D echo and using some color flow Doppler. And then in the middle line, you're going to have to know your way around pressure and velocity relationships, and measuring TAPSE is something we can do as well as early scanners. And then if you really want to corroborate all your findings, you might look at that pulmonary artery mid-systolic notching and your pulmonary valve acceleration time, and that's how it leads you into your 60-60 sign if both of them are less than 60. And then really experimental work, your right ventricular free wall strain and speckle tracking. But, I think to have a look is the key piece to identify that right ventricle that is under strain, whichever method you tend to use. So whether it's B-mode imaging, as high quality B-mode imaging as you can find. And my take-home message is that the more echo signs that are present, the more likely that this is to be a right ventricle that's under strain, and it's going to nudge you in the direction of a patient that's going to need closer attention. So this is not somebody that should go to the ward. You should have a high level of kind of suspicion for this patient that's going to become more unstable. Again, this is just the performance characteristics of these signs, and these signs are described in how they diagnose a PE. So I'm talking about identifying right ventricular strain. But again, the take-home message from this is none of those signs really perform all that well at all. So I don't think we should diagnose PE on echo. I think we should steer well away from that if we can at all. Let's diagnose right ventricular strain as a result of those PE, and then identify early those ones that we're worried about. And I just want to wrap up and say, those of you that are starting out on your echo journey, and especially if you're doing some echo in the ED, start with good quality, high quality B-mode 2D images. Get as many of the different standard views as possible. Consider adding color to valves. It's very useful, but only when you have good views. Doppler is definitely an advanced skill and relies on high quality views and in your ability to interpret that and get right angles and understand the Doppler physics. So I see echo findings, certainly in this case, they're data points, and you need as many of them as possible to build up the case. And then my last piece of advice would be, don't rely just on your echo alone. You really must combine these with clinical suspicion and clinical components of your exam. And this is really, really important. So don't let your echo run away with you. It must tally in with your clinical components as well. And with that, I'll hand back to Nick, and thanks everybody, and I will see what you have for questions.
So thank you very much, Kian. So in terms of questions here, so we have one here from Mike Olivier. I hope I'm pronouncing your name right. Who's an EM-ITU doctor. He's asking here, in a young person with confirmed PE and the echo findings you have just shown, but with normal tension in a center without clot retrieval, would you give thrombolysis based on those findings?
That's a nuanced question, isn't it? I'm going to need help from my expert panel. I suppose I'll tell you what I do where I work. I got on our silo group, our PERT team, and we kind of hummed and hawed and said, let's get this lady to ICU. We have a new interventionalist that's very adept with an angio or with an IR ability to go and do clot retrieval. So we got this person down and said, look, what do you think? What would you do if this patient goes off? And in the end, with the kind of group consensus, we figured out that this patient is a submassive PE, but definitely a right ventricle that we're concerned about. And we took the decision to start off with IV heparin. I suppose the next decision you'd need to make is, do you go for thrombolysis or do you ship the person out for clot retrieval? I haven't really answered your question. All I can do is tell you what I've done in our centre. I think it's very much dependent on the resources that you have in your centre at that time. What would the rest of the panel do?
I can tell you that in our shop now, we're the land of Josh Farkas from POMCRIT, and we're doing more half-dose lytics now for some of our patients who have pretty significant findings of RV strain on their scans, even though we are a center where we do have resources to do clot retrieval as well. So but I think this is now somewhat controversial and center dependent. I think if you're in a situation where you have a patient who's somewhat remote from the next medical center that's going to involve a transfer, putting them in the back of a box, I think we would err probably in our medical system of doing half-dose lytics.
And bear in mind as well, we thrombolyze strokes, with relative ease these days, and this is the same stroke clot lysis that we're giving, and yet we're quite hesitant to thrombolyze PE. So it's I think it's a tough question, but thank you for it.
I agree. Sorry, did you want to come in there, Peter?
Oh, go ahead.
I agree it's a tough question, and actually it's been great to attend some of the conferences that have been organised by the people on the PERT team from the matter that Kian has mentioned there. And having worked there for a brief period, I found myself giving half dose with consensus in one case and full dose in another case. And then after the conferences, I was almost quite disappointed to learn that oftentimes the IV heparin does the trick, and that seems to be the way much of the evidence is moving. Certainly, some of the people at the conferences who've dedicated a large portion of their research time to this and have studied this in great detail have found that, therapeutic heparin and time, the ones now that in our centre I've got on to my physician colleagues about usually have a tachycardia or have a rising BNP or a rising troponin and CT evidence of submassive PE that's liable to extend. So I agree, putting them in a monitored environment and maybe even making sure in our case we've alteplase, have the box nearby so we're not trying to find it in a hurry. But oftentimes if there's no tachycardia, no signs of hemodynamic instability and there aren't rising markers, the IV heparin seems to do the trick.
And yeah, I agree with everything you said there, Catherine. I suppose our guidelines, the European guidelines, the ESC guidelines would suggest thrombolysis in the case of a massive PE, meaning hypotension for greater than 15 minutes. If that isn't the case, it would be an NDT discussion if you think that. Unfortunately for us, we have a very interested hematologist who takes phone calls every hour of every day about this kind of thing. So she helps in those decisions. But yeah.
Doesn't it make you nervous though when you see your right ventricle just doing that, and it's you're going to sit that person up in a high acuity area to make sure that if they do change, you have the right staff around.
For sure, yeah, absolutely. Yeah. And I mean,
and there still is, this is an ongoing study project, and I think the argument that Josh has been pushing in our institution is the concept of someone who's younger, who's clearly having ventricular dysfunction based on clot burden, and what's the long-term prognosis for quality of life downstream from that. And so I think that's been one of the, again, not borne out yet in terms of long-term studies, but one of the arguments that we're getting from our pulmonologists here about half-dose lysis is that this is not only an acute decompensation issue, but we don't really understand yet what the long-term effects of having dilated ventricles for especially the younger population who have these massive clots and are going to have some longevity. So they're clearly pushing the envelope on making a decision now, betting that this is going to be a long-term benefit. But that's another aspect of the equation that we try and answer.
And Peter, just to come in on that, at the VTE conference, Prof. Gain actually presented a case of a marathon runner who couldn't run the marathons again. However, many patients that attended his clinic, he pointed out, actually never found out about their CTEPH because they didn't go running marathons. So it really does come down to the individual patient as well, doesn't it? And it is really difficult to prove what you're talking about in an evidence-based trial with high enough volume.
Yeah, I think the where it's uncertain, I think you need to get a consensus. I think it's the feel that I get from most of the panel.
For sure. I mean, if your patient becomes acutely unwell in front of you, you know which way you're going to go. But it's something we've talked about before. It's the extremes are easy to manage, but it's where you tend towards the mean. And where you start to enter this grey zone, that's where you need consensus.
And it isn't an insignificant number as well of the submassives that do poorly. It's something like 20% is what I remember learning from the VT conference within a short period of time.